Good afternoon. My name is Simon Horslen. I'm a pediatric hepatologist, a specialist in liver disease, and I've been asked to talk about liver transplantation for rare diseases. If you have any questions, please enter them in the question section of the app, and we'll endeavour to answer all the questions at the end. Thank you. So if we look at the NORD rare disease database, pretty much every single condition we deal with in pediatric hepatology, saving maybe fatty liver disease and viral hepatitis, is mentioned as a rare disease. This includes biliary atresia, which is by far the most common indication for liver transplantation. So I'm going to focus this on what we consider rare disorders for liver transplant, namely those genetic and metabolic conditions. So what is meant, the content really will include what is meant by metabolic disease, the indication for liver transplantation in these groups, post-transplant survival for these groups of diseases as a whole, and then I will briefly list specific conditions for which the liver transplantation has been carried out. But the bulk of this talk will be really how to determine the benefit and what are the challenges in offering liver transplantation as a treatment to these patients who do not have conventional liver disease very often. So metabolic disease, if you look at the definitions in the dictionary, one will say one caused by some defect in the chemical reactions of the cells of the body, which pretty much covers all diseases. Or as an adult definition would be the metabolic consequences of a systemic disease like type 2 diabetes. But this is often what adult physicians refer to as metabolic syndrome. But we are really focused on single enzyme defects and single gene defects. Now, if it's just the enzyme, it may exclude transport proteins, and there are several listed there, or it could be a single gene defect, but this will include embryological disorders of differentiation of tissues, such as Alagille syndrome and polycystic kidney disease. So it's still not completely clear, but we will really focus on those conditions that affect an enzyme, a transport protein, or a final product. Now, the liver is the chemical factory of the body. There's an old meta illustration showing many of the pathways that are involved in the liver, and this is not a comprehensive list, but as you can see, we can have defects in the metabolic pathway for bilirubin, carbohydrate metabolism, amino acids, and a whole list of other potential metabolic pathways. So if we look at congenital defects of hepatic metabolic pathways, they're single gene defects resulting in defective functioning of an enzyme, a cofactor, a transport protein, receptor, or exported product. Some of these pathways are found only in the liver, but some are also found in other tissues in the body. But we know that liver replacement may significantly reduce the effect of the disease. These are some of the categories that we consider in liver disease. A colleague of mine, Pat McKiernan, came up with this categorization. And as we say, there are gene defects that cause traditional liver disease with fibrosis leading to cirrhosis, such as alpha-1 antitrypsin deficiency, Wilson disease, certain tumors. And then there are some of these also have extrahepatic effects, such as certain glycogen storage diseases, cystic fibrosis, and progressive familial intrahepatic cholestasis type 1. And there are other patients that have defects that are confined to the liver, but they don't actually cause any scarring or structural alteration to the liver. These can include defects of bilirubin metabolism, like Crigler-Najjar syndrome, defects that affect oxalate metabolism and cause ultimately injury to other tissues. Hemophilias and a variety of other conditions. Some of these conditions that have no significant liver disease and can be corrected by liver transplant also have extrahepatic defects, such as the glycogen storage disease type 1b or the organic acidemias. So what are the indications for liver transplant in children with single gene defect? Well, actually, they're the same as indications for liver transplant for any condition. There are patients with metabolic disease that can present with acute liver failure, that is seemingly healthy, no liver disease previously, and suddenly the liver fails. You can have the more chronic liver disease where you get fibrosis, cirrhosis, and gradual loss of liver function. And you also have metabolic conditions that can lead to unresectable hepatic tumor. And here's some of the examples. Wilson disease often presents in childhood with acute liver failure. We see cirrhosis in alpha-1 antitrypsin deficiency, glycogen storage disease type 4, cystic fibrosis, and then liver tumors, particularly hepatocellular carcinoma and adenoma, can be seen in tyrosinemia, glycogen storage disease, and other conditions. And then finally, the largest group are really those that are caused by a defect in a pathway in the liver, but that defect leads to injury of extrahepatic tissues and not exactly liver disease itself. So if we look at the inborn errors of metabolism that cause injury outside the liver but are treatable by liver transplant, we have those that cause neurological injury, such as urea cycle disorders, organic acidemias, maple syrup urine disease, and of course bilirubin encephalopathy from Crigler-Najjar syndrome. There are defects that cause cardiac injury, such as familial hypercholesterolemia or propionic acidemia, and those that cause renal injury, such as hyperoxaluria type 1, and factor H and factor I deficiency, which are defects in complement stabilization. And then there are hematological injuries. Most of the pro and anticoagulant factors found in the blood are synthesized within the liver. And although we rarely transplant primarily for these defects, we certainly know that they are corrected by liver transplantation. So if we say these are a possible group of conditions that we can treat with liver transplantation, how well do they do after liver transplantation? And I've got a few studies from different databases that show very similar data. This was an analysis from the United States database from the United Network of Organ Sharing, and it looked at children with metabolic disorders over a period of time, identified over 500 pediatric liver transplant recipients for a primary diagnosis of metabolic, and this accounted for about 20% of the total pediatric liver transplants. It did not include cystic fibrosis or progressive familial intrahepatic cholestasis, and of these 551 patients, 2/3 had structural liver disease, so cirrhosis, such as alpha-1 antitrypsin deficiency, acute liver failure with Wilson's or tyrosinemia. And 1/3 had no liver fibrosis. That was Crigler-Najjar, organic acidemias, urea cycle disorders primarily. The patient survival was 94% and 92% at 1 and 5 years, with no difference between the groups with or without liver fibrosis. And these were better survival figures than in other pediatric groups. Now, this was somewhat dated set, and the outcome figures have improved even since this time. So we expect close to 100% 1-year survival in these patients. This is a group from London, similar sort of time span, 112 patients, was 17% of their pediatric experience. Again, didn't include cystic fibrosis or PFIC, And again, about 2/3 were cirrhotic and 1/3 were non-cirrhotic. We won't talk about their auxiliary liver transplant, but this is where you leave a part of the native liver in place and place an auxiliary liver piece beside that native liver. But their overall patient survival was in similar sort of area, and there was again no difference between those with and without liver injury. And this was from the SPLIT database. This was the Studies in Pediatric Liver Transplantation, which is now the Society of Pediatric Liver Transplantation. And these had nearly 500 pediatric liver transplants. It accounted for about 15% and included cystic fibrosis, but for some reason not the PFIC patients. This may be, I think the PFICs were excluded from these series because I don't think they were all, the genes were well worked out at this stage, at least in the early stages of the cohort. But again, you can see patient survival was excellent. And on this Kaplan-Meier, you can see that the outcome for the metabolic patients was actually better than all other patients. The next few slides will list the metabolic conditions that have been treated by liver transplantation and have been published in the medical literature. Now, it won't be totally comprehensive, but if I've missed any, they're single case reports. They're classified into, the first one will show those conditions that cause fibrotic liver disease and progress to cirrhosis. And then there'll be 3 tables with those with no structural liver disease. The first one will be the well-accepted indications for transplant. The next will be more uncommon conditions, but they're probably acceptable. And then the last one is either not indicated, or you have to be very, very selective and careful about transplanting those patients. So if we look here, we have a number of conditions, and where we know outcomes for the specific condition, I've listed some of the outcome numbers, but most of them are in the high 80s or 90s in terms of outcome. Alpha-1 antitrypsin deficiency and cystic fibrosis, certainly the most common. In our area of Pennsylvania, PFIC is a very common condition, but rare in the world generally. And outcomes are very good. One has to be careful with glycogen storage disease type 4 because even with no evidence of cardiac or neuro concerns at the time of cirrhosis and transplantation, they may occur later. And then the hereditary hemochromatosis is important to point out that metabolic conditions are not just pediatric issues. The majority of patients who are transplanted for hemochromatosis are adults. And we'll see on the next slide, there's another condition that has been very commonly transplanted for adults. So these are the ones that don't cause obvious liver injury. We see a lot of patients with urea cycle disorders. We've done in Pittsburgh a lot of patients with maple syrup urine disease with excellent outcomes, Kriegel and Najar. And then this one at the bottom is probably the most common metabolic condition that has been transplanted for, but this is entirely adults. There's over 2,000 cases of hereditary transthyretin amyloidosis that have been transplanted around the world, and the outcomes are generally good. These are rarer conditions, and they may respond to transplantation, but they're often not the primary indication, such as hemophilias or phenylketonurias. Those patients have been transplanted, usually because they've got some other reason for transplantation, but we do know that those metabolic conditions are then cured by the transplant. And finally, those that are very debatable. I'll talk a little bit more about mitochondrial conditions. Those are always very difficult because even in the face of liver disease with no apparent neurological involvement, other tissues can be involved later on, and outcomes may be poor because of that. Galactosemia and fructose intolerance really shouldn't need transplanting because They should be identified and managed appropriately. And Niemann-Pick C liver transplantation does not prevent the neurological progression. However, that neurological progression may be delayed by 10 or 15 years from infant liver failure, and so it is definitely debatable as to whether liver transplantation may be used as an option. Certainly there are many older adults who undergo liver transplantation without an expectation of 10-year survival. There has been a couple of case reports of peroxisomal disorders. One case in Belgium was still doing extremely well 17 years after transplant, but generally for the Zellweger type, transplantation really is not indicated. And for the last two conditions, both of those were transplanted and were unsuccessful in altering the disease course. When we look at mitochondrial cytopathies and liver transplantation, there have been several case reports and several small series of children undergoing liver transplantation. The numbers are small, they're relatively short follow-ups in the main, and there's almost certainly significant reporting bias. Most of the patients that got transplanted, particularly with POLG mutations and MPV17s, were undiagnosed at the time of transplantation. And as a general rule, POLG and MPV17 probably are not good options. All the conditions that seem to have been regularly transplanted have been mitochondrial depletion syndromes, and it does seem that if you have a DGUOK or a TRMU mutation without obvious neurological involvement, they may be the best to transplant. This is just one small series that was described of 75% of patients who were highly selected surviving at least 1 year, but most of them did have worsening of mitochondrial cytopathy overall. There is one exception to this, and mitochondrial neurogastrointestinal encephalomyopathy, known as meninge, is a defect of thymidine phosphorylase. And transplanting older kids and adults had a take-home message that said liver transplantation is effective at stabilizing the symptoms and nearly normalizing thymidine levels in these patients. And stem cell transplantation has been suggested as an alternative, but this may have an improved, liver transplantation may have an improved safety profile over bone marrow transplantation. So that is one condition, mitochondrial condition, that may well be a good indication for liver transplantation. So liver transplant can be done for metabolic diseases, but just because we can, does it mean that we should? And if we should, how do we determine which patients will benefit? So I've come up with a sort of theoretical, hypothetical list that says that liver transplantation would clearly be beneficial if we were very clear about the progression of the disease. We knew that it was going to have a poor outcome without transplantation, that there were no other effective treatments available, or other treatments have failed. If the transplant reverses the primary disease or at least prevents further injury, if transplantation is available and affordable, and if transplant is successful without complications and offers long-term survival. Now we'll go through these one at a time. We'll thinking about the progression of liver disease, of the disease in general. Disease progression can be very difficult. There are a whole spectrum of disease severities in all diseases, including these simple single gene defects. There are genotype-phenotype correlations, there are modifying genetic and epigenetic factors, and there are environmental influences that all alter the expectation of progression of a disease, and at least the rate of progression. There are some cases where progression is pretty clear. The neonatal onset, proximal hyperammonemic urea cycle disorders like CPS, ornithine transcarbamylase deficiency, and the neonatal onset citrullinemia it's pretty clear that they go on to poor neurological outcomes. And this is also true for some of the organic acidemias with repeated metabolic decompensations. Glycogen storage disease that has very difficult to control hypoglycemia, and obviously Wilson's disease presenting with acute liver failure. There is a score that was developed at King's College Hospital in London based on a lot of data from pre-transplant times where the outcome could be followed through, that can fairly accurately predict which patients with Wilson's disease will need liver transplantation. But there are others where it's really very unclear. Glycogen storage disease type 4, we've mentioned, has early cirrhosis, but can have cardiomyopathy and neurological involvement that occurs later, which can lead to what ultimately is a futile liver transplantation. It can be difficult, except in the most severe forms of primary hyperoxaluria, to determine the rate at which renal failure is going to occur. Familial hypercholesterolemia and several of the less severe progressive organic acidurias can be very difficult to predict how they're going to respond to standard treatments. Mitochondrial disease, as we mentioned, can be particularly challenging, and you have to be very careful in selecting patients for transplantation. No other effective treatments available, or all have failed. Well, there are alternative treatments for some conditions. We know that we have no alternative therapies at current for end-stage liver disease related to alpha-1 antitrypsin deficiency or fulminant Wilson's disease. We may try chelation therapy, but once they achieve those high scores on the King's scoring system, they're unlikely to respond to that acutely. There are potential therapies for Wilson's disease if you get it before they're fulminant, chelation therapy, zinc therapy, and there are other new medications coming down the pipeline. For the familial cholestasis syndromes, biliary diversion is advocated by many centers, and there's a whole new group of drugs that have just become FDA approved or are in the process of FDA approval that inhibit the uptake of bile acids from the terminal ileum and can alleviate many of the features of PFIC that are so troublesome to the patients. Dietary glycemic control can help with glycogen storage disease type 1 and 3. And for tyrosinemia, which was one of the original metabolic indications, now is very rarely needed to be transplanted because of this drug, nitisinone, NTBC, which blocks the production of the toxic metabolites in tyrosinemia. Low protein diet, benzoate, phenylacetate, butyrate can be used in urea cycle disorders. The organic acidemias are managed with dietary management, and phototherapy, tin protoporphyrin, has been used in Crigler-Najjar. In primary hyperoxaluria, dialysis and just individual renal transplantation has been advocated. And then there's a new drug, Oxlumo, which is a small interfering RNA, which blocks the production of glyoxylate, which is a precursor to oxalate and can limit the load, and is seemingly highly effective in managing patients with hyperoxaluria. And then there's been a whole bunch of drugs to deal with cholesterol metabolism in homozygous familial hypercholesterolemia, including apheresis as well, but they can be very involved. So how feasible are these alternatives? Well, they can be very effective. As we mentioned, for tyrosinemia, it really is rarely an indication for liver transplant now. But those treatments are not always effective in the cases of the urea cycle disorders and the organic acidemias with progressive neurological injury in spite of optimal management. They may be effective in preventing the progression of injury So chronic treatment of Wilson disease is very effective, but again, not so much so in some of the other conditions. I should remove the primary hyperoxaluria because of the new treatments that are available. Are they affordable? Well, most of these therapies are cumulatively very costly over a whole lifetime, and they can be extremely onerous. All-day phototherapy for the older child with Crigler-Najjar, complex and restricted diets, weekly apheresis can be very difficult for patients and families to maintain. Does transplant reverse the effects of the primary disease, or at least prevent further injury? That's certainly true in some conditions, but we do see disease recurrence after transplantation in erythropoietic protoporphyria, and in some cases of PFIC type 2, also known as bile salt export pump deficiency. Are we preventing metabolic decompensations? That certainly is true in glycogen storage disease type 1, urea cycle disorders and organic acidemias. But we rarely reverse any of the developmental delays or neurological defects that exist, but hopefully we can prevent further more occurring. Rarely you see a child with a metabolic encephalopathy that may improve a little with the transplant. Mostly they prevent further injury, but that's not always the case, as we mentioned in mitochondrial cytopathies. One other thing to consider in methylmalonic acidemia and propionic acidemia is metabolic stroke can still occur, presumably due to inherent neuronal metabolism of these amino acids and organic acids, rather than it being affected by the circulating level of metabolites. Renal injury can still occur in glycogen storage disease type 1, tyrosinemia, MMA, and often for methylmalonic acidemia and even propionic acidemia. You sometimes have to consider a combined liver and kidney transplantation, as you also need to do in advanced primary hyperoxaluria. And there are other conditions where you have cardiac disease that may occur despite transplantation in glycogen storage disease type 4, but hopefully in propionic acidemia and familial hypercholesterolemia, you will prevent the onset of further cardiac disease, although you're not likely to reverse any atheroma that you already have from your familial hypercholesterolemia. Is transplantation available? And this may seem a silly question, but interestingly, for metabolic conditions, they're not always referred to a transplant. So if you're not referred for transplant, you can't get a transplant. We are very lucky here in Pittsburgh to have a genetics department that helps us completely with selecting the patients for transplant and recognizing the benefits. But I've certainly met lots of families who have been told that transplantation is not a good option, that they should never approach a transplant program, and this can be disheartening, particularly if the families then find the transplant service themselves and realize that they've missed opportunities. The families may be given inaccurate information. Referrals may be delayed or non-existent. I've seen Crigler-Najjar patients who are spending 18 or more hours a day under lights, missing school, when they could have been transplanted much earlier. Interestingly, if you look in metabolic texts and the online material, there's actually very little on transplant. And as a rule, medical advisory boards for metabolic support groups rarely have a transplant expert on their panels. And then if they do get to a transplant program, do they get sufficient priority on the list to get transplanted? We've worked on this at a national level over the last 20 years. Obviously, the patients with chronic liver disease get judged on the basis of all those patients with cirrhosis, based on a score called the Meld-Peld score. Wilson's disease that presents in a fulminant fashion also gets the very high status of 1A, and the hyperammonemic conditions also do. Because of the complexities of primary hyperoxaluria, there is a standard exception scores that have been accepted, but all others we need to put into the National Review Board to get them some status on the liver transplant wait list. And then finally, it's important that you know, if you're going to do these sort of transplants, that there's expertise. And as I already mentioned, in Pittsburgh, we have an expert, an interested group of geneticists that help us greatly with these decisions and the management of the patients. But it's also important that your anesthesia staff understand the importance of metabolic stability going into transplantation. And then there may be need for ongoing control of diet even after transplantation. And again, that expertise is not available at all transplant centers. Is it affordable? Well, this varies depending upon the healthcare system. In the United States, children are generally covered by their family's insurance or by Medicaid, but there are other parts of the world where you know, transplantation can be very expensive. The important thing about transplantation, compared with many of the non-transplant management of these patients, is that we do understand the costs in transplantation. Obviously, they're very high at the front end with the operation and the initial immunosuppression, but they do diminish as the years of survival go on. We certainly know that costs for non-transplant care, lifelong dietary management with special formulas, lights, apheresis can be cumulatively very expensive. But there's actually very little cost effectiveness data. We did a Markov model, created a Markov model to look at the cost effectiveness of liver transplantation for methylmalonic and propionic acidemia. There are a large number of assumptions based on any Markov model, but based on that model, liver transplantation looked like an economically very reasonable proposal for patients with these conditions. And finally, is it successful without complications and offers long-term survival? Well, of course, we know no surgical procedure is free of complications, but outcomes in terms of survival continue to improve. Compared with when we started in the 1980s, the outcomes are spectacular, but can always be better. Short and medium-term complications are very well recognized, and we're used to managing them. We're now looking in a lot of detail at very long-term outcomes, 15, 30 years plus outcomes. We don't have much data on 40-year outcomes because we just haven't been doing transplantation for that long. But livers, particularly if they can get through the adolescent and early adult times when people tend to be less than careful about their medications, they seem to have a very long-lasting function. But we do need to be very open with families because they are exchanging one set of problems for potentially others. Now, in the neonatal onset urea cycle disorders, where you know they're going to have profound neurological consequences, the decision to transplant can be relatively easy. However, if you're looking at an older child with late onset urea cycle disorder who needs protein restriction but rarely has decompensations and has a stable intellect, it can be much more difficult, and the decision to transplant often comes down to quality of life decisions, which will vary from one patient and one family to another. There are, of course, further challenges. I can't list them all because they're huge, but here are a few. Other treatments are available for some diseases, and new therapies are coming online every year, as I mentioned with the the treatment for primary hyperoxaluria. But there are really no comparative studies, no studies between the different treatment options, and no studies between transplantation or timing of transplantation with these other therapies. Much of that is due to the fact that all of these are rare conditions with very small numbers. So they would be very, very difficult studies to do anyway. Another question is, when does the treatment disturb quality of life sufficient? Not just the treatment, but the disease itself disturb quality of life sufficient to justify risks of transplantation. Judging quality of life is always very difficult. We know as physicians it's not our place to determine what someone's quality of life is. We often do it by parental proxies, and we have to wait quite a few years before we can actually get the patients to judge those quality of life themselves. And in fact, whose quality of life is being improved? Sometimes with a metabolic disease and a child that's fully dependent, it's the parents' quality of life, the ability for carers to spend time with their other children and get on with all the normal functions of families that are actually being improved. So these are difficult questions. Another question is, how do we justify using a deceased donor liver in a patient who is being managed with other treatments when there are patients who are dying of liver disease on the liver transplant list? We certainly transplant quite a number of patients with maple syrup urine disease and other metabolic conditions for quality of life reasons, and justifying that in the face of an increasing wait list mortality on the adult list can be difficult. And then how much priority do you give them on the wait list? Does a metabolic patient have a greater priority than a baby with biliary atresia and a failing liver? Again, this is something that we do have to work out, because we certainly see some metabolic patients who are relatively stable having higher priorities than some of our kids with decompensating liver disease. And then we're always looking for that gene therapy, the cellular therapy, gene editing therapies that always seem to be on the horizon. It's always been 5 or 10 years away, and it doesn't matter how far you go back. When I was a medical student, I was being promised them in 5 or 10 years, and we're still being promised them in 5 or 10 years. So we keep watching the science and the development and hoping that there will be alternatives to whole organ replacement, but those are not here yet. So here's a quick testimonial. This was published in a organic acidemia newsletter. It was a patient of mine. Parents gave me permission. They wanted me to use her real name. And this was a young lady who had methylmalonic acidemia, whose physicians had told them not to contemplate transplantation because the outcomes are really poor, having no experience with transplantation. But the family found us, and this was Caitlin 3 days after liver transplantation. And these are the words that her parents said. You know, she came in, she could hardly walk, she was in a haze. So for the last year, we have gotten to know a whole new kid. Before transplant, she was always kind of dazed and in a fog. She's now witty and funny, talks all the time. She can tell us about her day in great detail, which is so exciting. She has learned to ride a bike, loves to race us running. Her endurance is what has been the biggest change. Before transplantation, she could barely walk from the couch to her room without being tired. We had to push her in a chair if we left the house. We feel this is a large weight lifted from our family, and the quality of life for us all has changed tremendously. Caitlin will be attending summer camp and has been an avid tennis player. Our Caitlin was locked inside herself for 13 years, and now she's living as a typical kid. And when I last saw her, she was 18, 19. She still needs support because those 13 years of metabolic derangement had some effect, but her liver function was was great. She's never had any rejections or complications of the disease. So in conclusion, transplantation for liver-based metabolic diseases can be life-saving or positively life-changing. The decision-making may be difficult particularly when alternative therapies exist, or whether the balance of benefit is not absolutely clear. But a consensus decision between the transplant team, metabolic geneticists, and the family should always be sought. And outcomes may be excellent, but families deserve a balanced assessment of potential benefits and complications that transplantation may bring. And thank you for listening. This is another one of our patients who had alpha-1 antitrypsin deficiency, enjoying all the good things that Seattle can offer from when I worked there. So I'm very happy to answer any questions that the audience may have. Thank you. Well, thank you for listening. Obviously, there's no questions coming through in the question section.
I pushed a question over to you.
Oh, did you? Let's
Yes.
have a look. Here we go. I see MSUD on the list of significant liver disease, but don't see PKU. Is this not considered a liver metabolic disease? Yeah, PKU is a liver metabolic disease, but the general feeling is that the nutritional management of PKU and the progression does not, in most instances, justify the moving forward with liver transplantation. Really, the acute decompensations is what we're trying to prevent with the maple syrup urine disease, whereas with PKU, it's much more of a chronic condition. Certainly, PKU has been transplanted. It was on one of the lists, but usually it's because those patients have got some other condition. I've certainly looked after a patient who had alpha-1 antitrypsin deficiency and PKU, and their PKU was resolved on liver transplantation. There have been other patients who had PKU and hepatitis C that have also been transplanted, and it's effective treatment. I think it could be a very good treatment for PKU. There are ongoing trials of cellular therapy for PKU, but as a general rule, we have not had PKU patients stepping forward for whole organ transplantation. Cholangiocarcinoma is a liver disease. It is associated with some of the liver diseases that we deal with, such as primary sclerosing cholangitis. It has been described in MDR3 deficiency, PFIC type 3, and after choledochal cyst. But it's not primarily a metabolic disorder. Cholangiocarcinoma tends to present very late. There are a couple of transplant programs around the country that specialize in assessing and transplanting them, but the outcomes tend to be very poor. Fortunately, it is extremely uncommon in children, but of the children that I have seen with cholangiocarcinoma, even after transplant, recurrence is very high. So it's a nasty tumor to have. Okay, so no further questions at this time. Feel free. I'll just say thank you for everybody for listening. There is awful lot more to liver transplantation for rare diseases, including the medical and surgical management, but obviously we don't have time to cover every aspect. But thank you for listening, and I hope that it was informative. Thank you.